This video presentation and its accompanying materials are copyrighted by the American Association for Respiratory Care, AARC. Any public display, sale, copy, or distribution of the video or materials may only be undertaken with the prior written consent of the AARC. As a registered participant, you are authorized to duplicate course materials for this program for each participant viewing at your facility. This presentation and accompanying materials can be used by staff within the institution, but cannot be resold, distributed, or displayed for profit. Copyright 2016, all rights reserved. The following is a presentation of the American Association for Respiratory Care. Welcome to Current Topics in Respiratory Care. Today's topic is e-cigarettes, the science behind the smoke and mirrors. Dr. Nathan Cobb is an assistant professor at MedStar Georgetown University Hospital in Washington, D.C. Dr. Cobb has no conflicts of interest related to this presentation. Any use of brand names is not in any way meant to be an endorsement of a specific product, but to merely illustrate a point of emphasis.
My name is Dean Hess. I'm from Boston, and it's my pleasure to moderate this session. And it's my pleasure for several reasons. This is the 31st Philip Kittredge Memorial Lecture, and I knew Phil when he was alive and considered Phil a close friend of mine. It's also my privilege to moderate this session because this morning's speaker, Dr. Nate Cobb, I worked with when he did his Pulmonary and Critical Care Fellowship in Boston. So it's a little bit of a reunion in that regard. Dr. Cobb is pulmonary and critical care physician and researcher at Georgetown University in Washington, D.C. He attended medical school at Boston University and completed his internship, residency, and fellowship at Beth Israel Deaconess Hospital. And that fellowship was part of the Harvard Combined program. So unfortunately, maybe for Dr. Cobb, he had to rotate through the MICU at Mass General, where he had to listen to me pontificating at 7 a.m. and in the afternoons and so forth. So I hope that did not leave too much of a scar on Dr. Cobb. In medical school, Dr. Cobb developed one of the first online behavioral health platforms, a system for smoking cessation, which led to a position at the Legacy Foundation in Washington, D.C., and NIH funding to study the efficacy of online cessation systems and their associated social dynamics. Dr. Cobb's presentation this morning is entitled E-Cigarettes, the Science Behind the Smoke and Mirrors. Dr. Cobb?
Thank you, Dean. It's a real pleasure and an honor to be here. Dean did not torture me. I learned an awful lot about vent mechanics from Dean. And for me, it's an honor to be here talking to you all because I still, as a practicing MICU physician, depend upon my RTs and folks to get through every single call night. I'm going to talk a little bit today about electronic cigarettes. In particular, I'm going to talk not just about what we know, but an awful lot about what we don't know. And I think in many ways that's more important. By the end of this, I hope that you all will have heard enough from me that if you're wondering how you talk to your own patients about them, that you'll have much better ideas about how to answer those questions. I got interested in this topic a number of years ago. In fact, what happened was an intern walked into my office and he had an electronic cigarette with him, one of the old school models. And he handed it to me and he said, "I'm sure you know what this is. I'm sure you know all about it, but I don't. So can you tell me?" And being the good academic physician, I said, well, of course I do, but you tell me first what you know. We quickly established that neither of us knew anything. And in fact, that pretty much nobody knew anything at that point. So what we did was we took that device apart, and we actually took some of the fluid out of it and a couple of other devices and sent it off to a lab and asked the lab to tell us what was in it, what the constituents were. And we were pretty excited when we were going to publish this and write it up. And we actually got scooped by the FDA, who had done exactly the same thing a few months before. When they wrote up their results, they found a number of contaminants in the solution. We didn't, but they did. And this led to a feeling that the FDA was probably going to get involved in electronic cigarettes, that perhaps this was going to be a passing fad, that they'd be regulated perhaps out of existence. But actually what happened was the FDA stepped back. The courts told the FDA as they attempted to regulate e-cigarettes now back in 2009 that they couldn't do that. That under existing law, e-cigarettes are a tobacco product, not a drug delivery device as the FDA wanted. And it's because of that ruling, today, we find ourselves almost exactly where we were in 2009, with a proliferation of e-cigarette devices across the country that we know little about, that are very different in construction, and ultimately, we have lots of questions about from ourselves, as researchers, as physicians, as respiratory therapists, but also patients. So when I was putting together the slides for this, the title we'd chosen was Smoke and Mirrors as a metaphor. And it occurred to me that perhaps that was the wrong metaphor. It's an easy one, but maybe wolves in sheep clothing is a better metaphor. So what are these devices? Ultimately, when you think about an e-cigarette, is this something that we've mistaken for being safe, but ultimately there are public health implications that are much deeper? So have we made a mistake by letting them onto the market? In reality, what we're going to see is that as people start using them more and more, public health implications that perhaps this is going to perpetuate the tobacco epidemic, that perhaps they're going to be less safe than we thought, that there are going to be more and more issues with contamination. Or maybe we have it completely backwards. Maybe that we've made the mistake of anchoring ourselves, thinking that because we call them e-cigarettes, that they sort of are cigarettes, and that they inherit some of the dangers and the problems from cigarettes and are similar. But in reality, what they more are is simply nicotine, and they're ultimately, despite looking like cigarettes, are inherently safe. Or a third possible metaphor, old dog, new tricks. Maybe in reality, these are just nicotine replacement. Maybe we've got ourselves confused. Maybe what they are is a new variant of the nicotine inhaler, and we've just let this out onto the market without regulation, but it's essentially the same thing that we've always done. So we're going to talk to you all for probably about 45 minutes, then I'll try and leave time for questions because people always seem to want to talk a little bit more. We'll talk a little bit about definitions, about prevalence, what we know about who uses them, what we know about who doesn't use them, safety and efficacy, both of which we don't know an awful lot about, public health implications, and something of what's coming down the pike in regulations or what we think might be, and ultimately how I at least try and address patient questions and family member questions. So it's reasonable to start with definitions. I like to start with the definition of a cigarette, because if we're going to call these things e-cigarettes, it matters what we're comparing them to. So if you go back to the dictionary, I like the Oxford American Dictionary, it'll define a cigarette for you as a slender roll of cut tobacco enclosed in paper meant to be smoked. This comes from the French, which ultimately comes from the Spanish, and in this dictionary, but in many other ones, comes from the Mayan for tobacco, which is, when you think about it, it sounds obvious, but by definition, a cigarette is made of tobacco. It is tobacco. And that's what the law says. But that puts it in sharp opposition to an e-cigarette, which is almost defined in reality by not having tobacco. An e-cigarette, and this is sort of what many people think of as a classic device. It's what you might find if you look it up in Google and look for an image. In fact, most of the images I'll show you I found online and come straight from manufacturers' websites. This is a prototypical device. It has a battery embedded in the back portion there. It's got a reservoir here, which takes a cartridge. Cartridge usually has some sort of fiber in it, which is soaked with propylene glycol and a nicotine solution. That comes into contact with a heating element. The heating element is connected to a switch, usually a flow sensor in these models. And when somebody inhales on the assembled device, the switch throws. It connects to the heating element. The battery causes the heating element to heat up. The propylene glycol vaporizes, carrying the nicotine with it in sort of a theatrical fog, which the user then inhales. And often when you see them exhale, you can see this theatrical fog come out. Now, that's sort of what we think of them traditionally as, or what they've been since, say, 2007. When they first came on the market in the US, which was about 2007, they were fairly new to all of us. They were invented theoretically. I don't know if the story is true, but there's a patent from a guy out of Hong Kong in 2002, and they sort of snuck onto the market in Europe and the US in sort of around 2007. As we started to look at these, the WHO weighed in with a definition of what they thought it was. The WHO says they are devices designed to deliver nicotine into the lungs, to draw a mixture of air and vapors into the respiratory system, that they contain electronic vaporization systems, a rechargeable battery. They get very specific, down to the fact that they have replaceable cartridges. The FDA, on the other hand, has struggled with definitions a little bit. If you go into their proposed regulations, which are hopefully going to come out soon, they don't actually have a definition for what it is that they're going to regulate. They've deemed that e-cigarettes, these nicotine-containing products, are something that should be covered by their regulations, but they don't actually give a definition. On their website, however, they do offer a definition, and that says, battery-operated products designed to deliver nicotine, flavor, and other chemicals. They turn chemicals, including highly addictive nicotine, into an aerosol that is inhaled by the user. Now, I think that's a bit more useful, but it's also fairly specific. A few years ago, my group had the opportunity to write an editorial for the New England Journal. And we went back to these definitions and we asked the cartoonist or the illustrator to draw something for us. And this is what he came up with. And this is a nice cut section of exactly that. And it goes through all those definition elements, right? The rechargeable battery, the LED light that lights up, the nicotine-containing cartridge. But it turns out that when you take what this seems to be, and you compare it against what we actually see, either if you go into 7-Eleven, or more likely if you look at what your own patients use or what people are using in the street, there's a mismatch. This is one of the first things that we saw as a modification. And it's actually a traditional e-cigarette hooked up to a USB plug. And the reason that people do this, or the reason these are sold, is it turns out that you can go through a standard battery in an e-cigarette very quickly. And the folks who are using these, they're puffing on them, vaping on them, as they say, find that in order to get an adequate dose of nicotine, that they have to use them an awful lot longer than you'd use just a traditional cigarette. So they run the batteries down. They have to wait for their battery to recharge. While they can refill the solution fairly quickly, they get annoyed having to wait for the battery to recharge. So this is an alternative to having multiple recharging devices. And people will actually just plug these into their computer or into an iPhone charger and so on, and it lets them sort of vape throughout the day. This is another model. These models go by different names, but usually they're called tank models or similar. And the first thing you'll notice is that in the center, there's a reservoir instead of a cartridge. And people will just fill this reservoir with a propylene glycol usually and nicotine solution. Other humectants, other forms of carrier are used, usually glycerin. But for the most part, it's propylene glycol. And this makes it a lot easier for the user, but it makes it a lot less controlled. They'll go out and buy nicotine solution at a vape shop or online, and they pour it into that reservoir. The other thing that's different here is obviously that the battery is a lot larger, so it doesn't run down as fast. And in the middle is a black dot. And that black dot replaces what was traditionally the flow sensor. So it turns out that when, in a traditional device, if you inhale on it, that switch has to throw, and then the heating element has to fire up, and that takes a second. And in that time, they're not getting anything. So this allows much finer grain control for the user. They're able to push on that button, the heating element heats up, then they inhale, and they get the quick hit as they're expecting it. This is a bunch of other devices, the same sort of class. And I think what you'll notice very quickly is that they don't look like cigarettes anymore. Right? In fact, they sort of look like medical devices, maybe, that you might see on a science fiction show. But they no longer look like cigarettes. And this is part of the issue as we get to what it is that we're talking about with ourselves, with patients, with the FDA and regulation. And at the end of the day, probably calling e-cigarettes is a mistake. They're not really cigarettes. They don't have an awful lot to do with tobacco or cigarettes. They're refined nicotine. They don't have to have rechargeable batteries. They probably don't have to have batteries at all. In fact, an alternative definition for these is really they're just sort of inhalers. They're vaporizers for refined nicotine products. And once you get back to that, I think it helps us put them into perspective for exactly what they are, but also what the true risks and benefits might be, both at an individual level and at a public health level. We're starting to have better data on who actually uses them, and this is from 2014 data from the federal government that just came out, was released pretty recently. And it's pretty stunning in reality. And so on the left side, you have the people who have ever tried an e-cigarette at all. And what we see in this graph is that almost 50% of smokers have tried an e-cigarette at some point. And over 50% of people who quit in the last year have tried one. So when you think about sort of these devices and when you see them around and you hear about them, I think sometimes it's hard to think about the scope. How common are they? Is this just sort of a media fascination? Is it something that we like to talk to? Is it one of those things that some of our patients who are more talkative show up with? No, it looks like this is real, right? People actually use these things. On the right side is a percentage of people who actively use them. And what we find is about 16% of current smokers dual use. So they also, in addition to using combusted tobacco, they also use e-cigarettes. And interestingly, 22% of people who have quit in the last year also are currently using e-cigarettes. Now you can interpret this in a couple of ways. One way to think of this is that indicates that an awful lot of people are quitting using e-cigarettes. But 22% of people who have recently quit are still using e-cigarettes indicates that they probably had something to do with it. That's certainly possible, and that goes along with what we like to think about nicotine replacement, right? With nicotine replacement, despite the fact we have 5 forms of nicotine replacement in the market, the gum, the patch, the lozenge, the nasal spray, and ultimately the inhaler, people don't use them. It's really hard to get folks to use them. But here all of a sudden we have people going out of their way, purchasing nicotine and using it. But we don't know that this is true causation. We don't know that actually these people are quitting because of this, or perhaps they would have quit earlier, they would have quit differently, or these are the same people that just were going to quit on their own. So correlation is not causation, but it's very suggestive. And it gets to the fact that a lot of people really are using these. The next question that people often ask and worry about is, what about kids? What about adolescents? And this is a big deal, and we know even less about adolescents. The best data that we have is from 2011 and 2012, although hopefully we'll have more soon. And in this, I think the key part is, if we can't say today what the rates are, at least the rate of rise between these 2 years is interesting. So in high school students, the rate of students ever having tried an e-cigarette went from 5% to 10% over the course of a year between 2011 and 2012. Not shown in this graph is equally interesting is the patterns of use that we see, which are similar for adults, which is that individuals that use e-cigarettes are often tobacco smokers concurrently. They're dual users. But very rarely do we see either adolescents or adults who don't smoke and have never smoked trying an e-cigarette. Now, this could mean a few things. The first is that it's possible that these really aren't a problem, that really their use is isolated to people who otherwise use tobacco. The second concern, which is theoretical, but worries a lot of us, is that actually what we're seeing is that students, for example, in high school, once they try an e-cigarette, rapidly progress to smoking traditional cigarettes. That because the delivery of nicotine isn't very good, they like it, it's normalized behavior, and they go out and try a traditional cigarette. Now, there's no data for this. This is a concern, a worry, it's theoretical. But this gets to sort of the problem with these devices. Without having regulation, without having good data on them, we don't really know what's going on. So there have been a lot of safety concerns about these things raised. You'll get it in the media. We get it in questions. It's also been raised in the academic literature. And all of them are real, and I'll go through a bunch of them for you. But also I think it's important to put them in perspective. The electronics in these things are fairly simple by comparison to, say, the computer on my desk here. But they are real. Lithium-ion batteries, for the most of them, are what are used to drive the heating elements. Lithium-ion batteries are rechargeable. They require a certain circuit to recharge, to put energy back into the battery. When these things go wrong, the batteries can actually explode. This is why you're no longer allowed to carry an e-cigarette in checked baggage when you fly, because the concerns out of the airline safety folks is that they may explode in baggage. This isn't just theoretical. There have been explosions of these devices while people are smoking them. Obviously, if you're using something in close conjunction to your face, it's a bigger deal if it lights on fire. But that's not to say that they're always going to be that way. Obviously, we have electronics that are very similar that we give to small children that don't have problems. So this is mostly a regulatory problem. Nicotine toxicity is a big deal for a lot of people, but it's not what you may think. So most of these devices will deliver they're set for a cartridge to have a similar amount of nicotine that you might find in a traditional cigarette. That's not an awful lot of nicotine. In fact, it's low enough in that if a child were to eat a cartridge, they'd probably just vomit. The real concern is that how these are actually refilled. And folks can go out and buy refill solutions for most of these devices, particularly the tank models. They can buy them online. They can buy them in local vape shops. And those refill solutions come in a number of different styles, often with very high concentrations. And these have been associated with a number of ingestions, including in toddlers, particularly from sort of the forms that are flavored, cherry flavored, and so on. There's been one reported death. There's been another number of other severe poisonings. So sort of the distribution of nicotine to refill these devices remains a real concern. But again, that's mostly regulatory. This isn't a problem that we have with most other drugs. Most other drugs of similar risk are well controlled. The inhalation of propylene glycol and glycerin is a real concern. And this is probably one of the bigger ones that we're still trying to get a handle on. So all of these devices use some form of humectant. Some of the older ones use things like vegetable oil, which seems to work fine, except for it's been associated with things like lipoid pneumonia, things that you really wouldn't want. So the bulk of them now use propylene glycol, and a smaller number use glycerin. Propylene glycol is relatively safe. It's used in sort of foodstuffs and cosmetics throughout the world. It's fairly well regulated. There are standard ways of controlling our supply chain here in the US. It's no longer used for the most part in injection solutions after we had problems using it as a carrier for Ativan with severe acidosis. But it really doesn't have much of a track record for inhalation. So as you all probably know, it's not something that we use with any sort of vaporizer or inhaler. It's been used for a long time in theatrical fog. So on stage, it'll be used to create sort of the fog that you might see. And in those cases, it's also been unfortunately associated with cough and some respiratory irritability. So we don't know enough. Most of the data is fairly old. But particularly what we don't know is what happens if you inhale propylene glycol for 20 years or glycerin. So this remains a real concern, and one of the ones that will be the hardest for us to solve. Ultrafine particles and heating byproducts are a significant concern. So when you think about it, you sample the solution that goes into these things and you get propylene glycol and nicotine in the cleanest solutions. That seems fairly safe. But it all changes once you put it into a heating compartment, heat that up to a sufficient temperature for it to vaporize. So what people find when they actually sample the product, the vapor that people inhale, is that they find all sorts of other heating byproducts which may be carcinogenic, and they find some of the off-cast from the heating element, including metals such as tin and stuff that we do know can be dangerous if inhaled, particularly over time. And the last concern is contamination. And this again comes back to regulation as one of the ones that I at least worry the most about. In 1937, the FDA was a shadow of its current self. And then something called the Massengill event happened. Massengill was a small pharmaceutical supplier. They created an elixir of sulfonamide, antibiotic solution, to sell into the market. And like most pharmaceutical companies in those days, their chemists quickly put something together. They thought it through. They created the elixir and they sold it. And in this case, they used diethylene glycol. Diethylene glycol is very similar to propylene glycol, colorless, odorless. It's a great solution. We still use it in things like brake fluid. But diethylene glycol, unfortunately, is terribly toxic, causes renal failure in even small doses. So this went out, and a lot of people died, and a team was put together to track it all down. And that led to the formation, essentially, the empowerment of the FDA to oversee our food chain and our drug supply today. You might think that diethylene glycol after that is no longer a problem, but since the 1960s, there have been a dozen mass poisonings across the world from diethylene glycol in things like toothpaste, Tylenol solution, cough syrup. And almost all of these come from the same thing, which is the inadvertent substitution of diethylene glycol for propylene glycol. Usually it's a manufacturer in China or somewhere else. Somebody's running low on propylene glycol, makes a mistake about which batch is which, something gets mixed in, and all of a sudden, some kid in Haiti is brushing their teeth with diethylene glycol. Here in the US, we have strict supply chain requirements. For example, if you sell glycerin, it's required to be tested for the presence of diethylene glycol before it can be shipped After being shipped, all of those labels have to follow it around. If you pay attention in the hospital, you'll notice that all of our stuff has the manufacturing certificates. But that's not the case if something's being sold outside a traditional supply chain or sold outside regulation. So here in the US and throughout the world, when people make e-cigarettes, they're cobbling them together often. These are usually small manufacturers, and they're putting stuff together out of the supply chains they have available to them. And so this is a screenshot of Amazon, where you can actually go, and if you want to be a small shop producing electronic cigarettes and the stuff that goes along with it, you can buy propylene glycol. As you notice, it's graded as food grade, but not all propylene glycol is food grade because it's not its only use. So one of the concerns in any product like this, particularly when there are many, many manufacturers, the vast majority of them imported from China, along with the chemicals, the propylene glycol and the nicotine that goes into them, is that we simply don't know what's in them. And that's a concern because one of the things that we normally think about when we think about any drug delivery device, and ultimately that's what these are, is that we think of them as a class. We think that the one that you have in your hand is similar to the one that your patient has, is similar to the one that's sold at CVS, that they're all fairly similar. And that you have a good idea that if somebody's going to use one, that the drugs are going to be fairly similar and that they're going to be safe. But with e-cigarettes, because they lack any form of regulation, we don't know that, but we also don't know that the device that you might recommend to a patient has the same effect profile as the one that was studied in an article that was published last year and so on. So this variability and lack of regulation impacts both safety and effect. So that's a lot of negative stuff about e-cigarettes, but it's not all negative. It's certainly not all negative. And I mentioned how we often anchor our thinking around a name. In this case, calling e-cigarettes cigarettes. It makes us think of them as that. But maybe that's not the right way to think of it, because obviously they really are just propylene glycol and nicotine and an inhaler of some sort. So maybe we should be thinking of them in a different context. Maybe we should be thinking of them as their close cousins as nicotine replacement. So the nicotine gum was one of the first products we had to deliver nicotine in an effort to help people quit smoking. It's effective. Effect rates for almost all nicotine replacement products are about 2x. They double your quit rates when used with behavioral therapy. That's not great, given that most quit rates for people without help are on the order of maybe 8%, so it might take you from 8% to 15% in most studies, but it's a lot better than anything else, right? So being able to double cessation rates across the country, for us, once nicotine replacement became a viable product, was huge. Yet people don't use nicotine replacement. Uptake and use rates across the country still remain sort of 2 to 3% for most of these products, and getting folks to use them as part of their quits is hard. But they still fit in a continuum, and this is an important continuum, and this is part of the safety profile. A couple of years ago, a very smart group decided to put together a list of all of the nicotine-containing products on the market, everything from cigarettes to pipes to little cigars to snus, which is a form of essentially chew tobacco, then all the way down to the pharmaceutical products. And this wasn't an effort to figure out the harms to society in aggregate as it exists. This was an effort to try and figure out, compared to other products, or compared essentially to the cigarette, which is at 100 here, what are the harms of each individual product? Or put another way, if everybody switched from cigarettes to the pipe, what would the change in harm burden across the country look like? And what we see here is that small cigars are at about 65% of a cigarette. Now, small cigars are essentially cigarettes in the first place, so that's probably not very helpful. Pipes contribute about 20% to the same harm as a cigarette. And so in this model is everything from morbidity to mortality to economic costs. And for a cigarette, that makes up the bulk of what you see there. That's the red, the green, and the blue at the bottom. Cigars are less than pipes, water pipe, and so on. But these are all still fairly harmful. 20% of as harmful as a cigarette is pretty bad. But down at the other end, you have the patch and the other forms of nicotine replacement. And snuck in the middle there, between snus and nasal sprays, are ENDS. And that's the WHO term for e-cigarettes, electronic nicotine delivery systems. This is the key here, and this is the part that gets people really excited. And if we can figure out some of the regulatory and other safety problems, and really double down on making sure these things match this profile, then we have a huge opportunity, because at the end of the day, if they really are similar to the nicotine patch and safety profile, by definition of containing really not much more than propylene glycol and nicotine, then we have something that can substitute for cigarettes in the mass market and possibly completely change and contribute to what we call the end game of tobacco, and really change fundamentally the disease burden in the US. And quite honestly, you know, if this had happened 30 or 40 years ago, if we'd managed to cut tobacco use rates down below 10%, many of us wouldn't have jobs, which I'd be thankful for. My job, at least. So the question becomes really, again, what are they? Are these a cigarette, or are they an inhaler? And one of the least used devices out there for smoking cessation is the nicotine inhaler, which is marketed by Pfizer. It's been on the market for a long time. It was initially essentially a competitor to the e-cigarette. While it doesn't have a heating element, a small company built the first devices and marketed them, tried to get around the FDA and market them. They take a cartridge, and when you inhale on them, you have to suck pretty hard, but you basically get a nicotine vapor in a controlled fashion. Unlike e-cigarettes, what these do is they always give you the same amount. Once you take a certain number of puffs off of them, there's no more. You can't tamper with the cartridges and so on. But also very unlike the e-cigarette, you have to go to your physician to get a prescription. And they're also fairly expensive. And one of the things that comes up that we don't say things like this very often is they're very ugly. They're difficult to use and ugly. And that actually gets to consumer perceptions and what people choose. And if we can't market nicotine replacement to folks in a way that they actually feel comfortable using it, then we're not doing anybody a service at a public health level. So where's the nicotine for these come from then? I told you a little bit about propylene glycol. Nicotine has traditionally only had two uses. So for the past number of years, it's been in the pharmaceutical supply chain, where it's sold for nicotine replacement. It's a fairly small market. Prior to that, its only use was as a pesticide. And if you go back far enough, there are mentions in the old literature, and it's used as a poison, but it's not a very good poison. But now there's a whole new market, right? So the size of the e-cigarette market dwarfs the nicotine replacement, the pharmaceutical market. So if you want to know where you buy this, you can go into most cities, and I'm sure there are a number of them here in Tampa, and vape shops. People who use e-cigarettes often call themselves vapors, and the process of inhaling, vaping, will stock various nicotine solutions. And these are designed to refill sort of the tank versions or to put into some of the cartridges. And they come in all sorts of flavors, everything from sort of cherry and various bubblegum, odd flavors, to flavors that are designed to mimic both the feel in the back of the mouth and the flavor of traditional cigarettes. So you'll find a Marlboro and so on. Many shops mix them themselves using various sort of ingredients on top of the propylene glycol and the nicotine. When you ask where does this come from, it comes out of similar places, right? So the small shop goes online and it orders its nicotine from someone. It could order this all from a vendor, a larger company, or they put it together themselves. And this is a screenshot that I stole from the New York Times when they wrote an article on this a couple of years ago. And this is a company that will sell you nicotine over the internet. They're based in Guangzhou in China, and they ship straight to your door. So again, part of this, it's a dual-edged sword here. It's so easy for small manufacturers to put together these devices, which theoretically should be relatively safe and down on that curve somewhere near nicotine replacement, yet the supply chains are quite iffy. So the next big question is always, what do we know about how well they work, or even do they work? Which sort of implies the question of what does to work mean? I think a lot of us hope that they help people quit smoking, but that may not be why certain people are using them. Not everybody uses them because they want to quit smoking. To date, there's no really good randomized controlled data on whether or not these things work for smoking cessation. If you think about it, we have 5 forms of nicotine replacement in the market. I am not aware of any failed trial of nicotine replacement drugs. Certainly could be that pharmaceutical companies have run a 6th product that we haven't heard about and never published it. But the general opinion is that well-constructed nicotine therapy, if the dose is delivered consistently, works and doubles quit rates. So it seems like these things should be the 6th form of nicotine replacement. They should work. But the limited number of randomized controlled trials that have been run don't show that. We've only had one really well-run trial, and that showed no effect, and I'll show a little bit from that in a moment. There's some relatively well-done case studies, retrospective cohorts that suggest that people who use these devices are more likely to quit. But again, it's correlation, it's not causation. And there are a number of studies that show that e-cigarettes, when used, reduce urges to smoke and reduce cigarette consumption in dual users. That's probably the most important thing we know, which is one of the things that it indicates that the nicotine in these devices is working as expected, that perhaps individual devices that have been studied don't work as expected, but at least as a class, it does seem that delivering the nicotine in the propylene glycol vapor does drive some of the things we expect it to. This is a shot from the money graph from an article in The Lancet from a few years ago now. This is from 2013. And this was a very well done trial of electronic cigarettes from a specific manufacturer where they studied 21 milligram electronic cigarettes. So dosing tried to mimic fairly closely to what you would get in the nicotine patch or with traditional cigarettes. And they compared that to a placebo, so the same device with no nicotine, just the propylene glycol. And then they put in a third arm, which is what made this trial important. They put in a third arm, which was actually the nicotine patch. And as you look at the graph, and hopefully you can see some of this, around 90 days, probably 60 to 90 days, there looks like there is still a separation of the curve, right? So at the top is the nicotine electronic cigarette, and it seems to be outperforming. But by the end of the trial, out towards 6 months, the curves have closed, and there's no difference between the three arms. Now, there are a lot of things that you can interpret out of this. The first is there appears to be no difference. But the second is that something doesn't make sense, and that's that the patch fails to outperform the placebo inhaler, which caused a lot of angst amongst a lot of people. Two possible interpretations of this. One of them is simply that the patch doesn't work. And there are people out there that believe that the patch and the nicotine replacement in the real world just doesn't work very well. So in that sense, it's not surprising that the placebo inhaler performs similarly. The other possibility is that there's something about e-cigarettes that goes beyond the fact that they have nicotine in them, that there's something about the process, the mimicking of the behavior that actually makes these work even independent of the nicotine, and that because of that, the placebo electronic cigarette performed as well as the patch. Ultimately, we don't know. We need a lot more studies. We need studies with different devices, and we need a lot better ability to lock down the dose delivery of these devices, many of which are essentially consumer devices designed to be sold in 7-Eleven, not designed for research purposes. So why might this be the case? So there's been a lot of work trying to figure out what is it about these devices and their delivery of nicotine that changes or helps. So this is an older study done by a group out of Virginia, by a guy by the name of Tom Eisenberg. And what they did was they brought people into their lab, and they actually put an IV in so they could draw blood over a period of about 45 minutes. And then they had them smoke their own cigarette. And that's the top line you see there. And you see that people pretty quickly jump up to about 20 nanograms per milliliter of nicotine concentration in their blood. It's this abrupt spike that you see from the deposition of the smoke deep into the alveoli, and then the arterial uptake that drives addiction, that makes cigarettes so much more addictive than oral tobacco or any other forms out there. Then they asked these same users to puff on two variants, two different electronic cigarettes. So these are folks that have never used an electronic cigarettes. And then they had them puff on a placebo or a sham. And those are the lines at the bottom that you can't make the difference out between. They were all the same. There was almost no nicotine delivery in those. This confused everyone when this was published. And it was seen as an evidence that probably these things just, quote, didn't work, that they didn't deliver nicotine. But that's a confusing argument because there are all these people out there claiming that they're the best things since sliced bread, that they've helped them quit, that they're satisfying. So it didn't make sense. So the same group came back and they rebooted their approach and they thought about it again. And so this time, instead of having smokers come in who'd never used an e-cigarette, they had e-cigarette users come in and they said, just do whatever you normally do. And then they drew their blood. And what they found was that they showed the similar levels of nicotine as either a smoker or a user of NRT. But it was different. It took them longer to get up to those levels, and what they did was they puffed fairly hard and consistently on their electronic cigarettes. They did not treat them like cigarettes. So when we think about this, traditionally we think about something that we call puff typology. And most of the machines that we have to measure nicotine content out of cigarettes and all this make very rigid assumptions about how people use a cigarette. People don't use e-cigarettes like cigarettes. They inhale differently, they hold it in differently, they do it for longer periods of time. They act as if these are a vaporizer or an inhaler, not a cigarette. So again, anchoring gets in our way of evaluating the product's efficacy and how people use them. So the next question comes often, well, if that's the case, are there ways to improve this? Are there ways to make it so the delivery is more stable or even more aggressive? This is a graph from a paper that was done a number of years ago now, 5 years ago, by a group out of Duke. And they were working independently of e-cigarettes on very similar ideas of how nicotine could be delivered in an inhaler of some sort. And one of the problems with all of the attempts at nicotine inhalers is that the deposition is usually very proximal into the upper airways, the oral mucosa, and then you get venous delivery, slow uptake, and you don't get that hit that most smokers are craving. So it's felt to be inadequate. If you're a tobacco company, it's also inadequate because it's not as addictive. So what this group did was that they found that if they bonded the nicotine to pyruvate, it changed the molecular size and changed the deposition. And that deposition was then more distal and there was more arterial uptake. And as you can see here, the more of the nicotine pyruvate they delivered, the higher that initial dose and the initial serum concentration of nicotine. There's been no follow-up to this paper because the group turned around and sold the intellectual property to Philip Morris. The other tobacco companies have picked up similar intellectual property. So they're very interested in proving how these things work. The way they work now is not the way they're going to work in a few years. And what we expect them to do in terms of helping cessation, getting people off tobacco, are clearly not the same goals that the tobacco companies have. And they really all have, at this point, picked somebody up or developed in-house. So these are all of the big tobacco companies at this point. The first to pick up one was Lorillard. They acquired Blue. If you've seen ads with celebrities smoking e-cigarettes, it's probably Lorillard. But at this point, they all have something. Most of them are not branded under their own brand names. They're branded under completely different branding. But these are the bulk of what you'll see out there. So from a public health standpoint, what does all of this mean? Well, there's a lot of advantages out here if we can solve some of these problems. The first is simply that there's a huge opportunity to displace a combusted tobacco. If these things really work in the sense that somebody picks one up, they start using it, they smoke less, even the burden of harm decreased because people just cut their consumption in half is huge. There's a hope that based upon some of what we've seen in nicotine replacement performance, that if that happens, that if people just pick them up randomly to try them, just having that additional low-grade amount of nicotine on board is enough to trigger cessation. So broad-scale adoption and dissemination of these could contribute again to the end game. Some people think that they can denormalize smoking, which is kind of interesting when you think about it. But once these no longer look like cigarettes, once they start to look like those weird things you saw, then that person who's pulling out an obnoxious traditional cigarette with smoke, smelly smoke, then seems odd and out of place because there's an alternative. And if that happens, then perhaps e-cigarettes are normalized and traditional smoking is denormalized, driving people's smoking down. But all of these are theoretical, and they're matched by equal concerns, which are essentially in the opposite direction. So we still don't know what the harms from long-term inhalation of propylene glycol and other humectants are. And people argue that actually the problem is renormalization of smoking, that as we've gotten slowly over 20 years or so to get people to think of smoking as being something odd or different or something that we don't want to do, that this will change that. And particularly as these devices mimic traditional tobacco, that people will start to say, hey, it's not that bad. I saw so-and-so smoking one of those e-cigarettes. It's okay for me to continue smoking my regular cigarette. They certainly lessen the impact of smoke-free areas. So one of the ways we've really driven cessation over the past number of years is smoke-free zones, smoke-free workplaces. Any hospital, you usually have a buffer area where nobody can smoke. And it gets to the point where if you're a smoker, it's just difficult to smoke during the workday. And so it becomes easier to quit at some point. If you can pick up an e-cigarette and use it easily, surreptitiously or what have you, it will lessen the impact and make it less likely for you to quit. And there's concern that dual use actually may go in the other direction, that by letting people or encouraging people to have that available cigarette, it keeps them addicted at periods where they might be otherwise making decisions, where they might make a cessation attempt on vacation, they might take their e-cigarette instead. So what happens is that we really don't have consensus. This in reality has been one of the biggest schisms I've seen in the tobacco control and public health community in a very long time. It's pitted old mentors against students, allies against allies, and has fundamentally changed a lot of our meetings and how we talk to each other. Underlying this is, for many people, is a concern that some of this is about money. And this isn't really public health, but at the end of the day, it's similar. When a number of years ago, the states sued, the attorney generals sued the states, the states sued the tobacco companies, they settled with something called the Master Settlement Agreement, which created the Legacy Foundation that I worked for a number of years, funded all sorts of public health programs, and put certain restrictions on the tobacco companies. But most of that money continues to flow in one way or another, and it's hard to give up. And if e-cigarettes really do decimate the traditional combusted tobacco business, there are a lot of stakeholders out there, not just these for-profit companies, but also our own local, federal, and state governments that may even have sold these bonds from the MSA to pay for things, but they'll continue to have to pay those bonds off or continue to depend upon the revenue from cigarette taxes. So this is real, and one of the upshots of that is that there have been a move to increase taxes on e-cigarettes, so that those taxes push the price from e-cigarettes where they are now, which makes them very price competitive against cigarettes, to where they're almost as expensive as a cigarette or as expensive as nicotine replacement, thus taking away one of the incentives for people to use them in the first place. So I mentioned a few times that these things are unregulated, which is, I say it, and I think it sometimes doesn't strike people as odd as it might be. There's no other product that I know of in the United States that's not regulated. Pet food is heavily regulated. If you go to get something for your dog, it's regulated. All the ingredients and the contents are regulated. Even cigarettes are regulated. But e-cigarettes currently fall into a no-man's zone. They are neither regulated as drugs nor as tobacco. So the FDA has proposed, and they did this about a year ago, to regulate e-cigarettes as tobacco. This would require all e-cigarettes to be registered with the FDA before sold. They'd have to accurately label and disclose their ingredients. They'd be unable to sell them to kids, right? They can currently sell to kids, and they couldn't give out free samples. These regulations don't cover quality or safety controls. They don't cover the amount of nicotine. They don't cover any future design changes that might increase the amount of nicotine or move towards arterial delivery. They're very minimal regulations. It seems pretty clear that those are going to go through, but we don't know when. They'll probably take at least another year, probably closer to 2 years before e-cigarettes are regulated under this minimal set. But there's a second process that we don't know much about, which may fundamentally change everything. And the FDA has indicated that it may actually ask all e-cigarette manufacturers to go under something that's called pre-market approval. And that means that in order to sell their devices, they'd have to submit them to the FDA, where they'd be evaluated for safety, effect, public health impact. In order to do this, the manufacturers are responsible for submitting something that looks an awful lot like what a drug company is required to submit. That would be impossible for most of the small manufacturers and would limit the market in size essentially to a couple of the large independent manufacturers and the tobacco companies. Pharmaceutical manufacturers have indicated that they have no interest in entering this market. If that happened and the FDA does that and goes in this direction, it would certainly change the safety and effect profile of all of the devices on the market, but it would also in all likelihood mean that the bulk of them are manufactured by existing tobacco companies. And that may or may not be something that's in the public health interest and something that has a lot of people concerned right now. So bringing this all back around, I get asked an awful lot what good advice is for patients or for people who smoke. And sometimes people will actually just come up and ask me this, and I will think it's because I've published on this or written an article that they wrote, but it really isn't. They're just saying, you're a doctor, what do you think? And it's a hard question. But I think the key is always first to stress that the goal is to get off combusted tobacco. And that comes back to that continuum of harm, right? No matter what you choose, whether it's an e-cigarette or an NRT, or even frankly, snus or oral tobacco, the burden of harm of that compared to traditional combusted tobacco it's not even on the same scale. But the reality is, and people forget this, is that NRT is actually almost free these days. So anybody with insurance after the Affordable Care Act, NRT is required to be free twice a year by all insurers, unless you are unfortunate enough to have a grandfathered plan, which aren't that common. So one of the things I stress to folks if they're asking whether they should use an e-cigarette or not, is that traditional NRT, including the nicotine inhaler, is known to be safe and effective. It's widely available. You can pick it up at pretty much any pharmacy. And your insurer almost certainly pays for it completely, so it's free. And that's your best choice. But for people who've already started using e-cigarettes, that person that says, I've been using this thing, it seems to help, I'm thinking I'm cutting back, should I keep doing it? What should I do? My general answer is don't rock the boat. I can't tell you that that device that the person has in their hand is safe. I can't tell you that it's going to work. But if they think it's helping, the most important thing is that they're going to make that quit attempt and stick with it. So they might as well stick with the device they have and they think works. If that doesn't work, they can come back and make a second round attempt at this. Maybe they used traditional NRT the second time. One of the other things I recommend, and this is a little different, is I do recommend that they buy from one of the independent manufacturers. And I won't name them here, but you can find them online. Rather than purchasing it from somebody from one of the tobacco industries. And I think that the motives of the tobacco industry are not aligned with us as healthcare providers. They've demonstrated pretty clearly that they're not. And we don't know where they're going in the long term. So I'd prefer that it come from one of the large independent manufacturers. But I also recommend that they don't pick up the random devices. So it's often one of the big ones that you've seen on TV, but not one from a tobacco company. But the big part with this is always stressing to them that the goal is to get off the cigarettes and the combusted tobacco one way or another. And pretty much anything that you do that can get you there is worth doing.
You just touched on, I'm really surprised that pharmaceutical companies have not gotten involved with this nicotine replacement and had products that actually gradually decline in the quantity of nicotine. It seems like it's a win-win. And do you know why they've not participated in this?
Yeah, it's essentially how they distinguish themselves in the marketplace. And so they feel that for them to enter the e-cigarette market would be to contaminate their brand. There's also differences, each of the different segments, so big tobacco, pharma, and then the e-cigarette manufacturers have different interests. And what ultimately pharma would like, as well as big tobacco, would be for the e-cigarettes to go away and not to compete with them. Personally, what I would like to see is actually the rules changed for pharma, and for them to be told that they're under less regulation. So to take things down to the point where they can actually go into the market and more rapidly innovate. But currently, for them just to take their packaging requires a year-long process of approval through the FDA. But ultimately, the answer is for them, it's mostly about branding and not changing their branding to enter a market where they're not well known.